Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, BBRF's President and CEO. Today, Dr. Sarah Sperry will present a precision health approach to bipolar disorder. BBRF is the world's largest private funder of mental health research grants, supporting transformative discoveries in order to develop improved treatments, cures, and methods of prevention. The high quality of the research we fund is made possible by the BBRF Scientific Council. This group of 180 prominent mental health researchers reviews each grant application and selects the most promising ideas with the greatest potential to lead to breakthroughs. The Scientific Council guides the Foundation to fund creative and impactful basic, translational, and clinical research relevant to the whole spectrum of mental health. One reason that research funded by BBRF has had such a great impact is because we do not limit our focus to one illness or condition. Since 1987, the Foundation has awarded $450 million to fund more than 6,500 research grants around the world and across a broad spectrum of brain illnesses, including addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, OCD, post-traumatic stress, schizophrenia, as well as suicide prevention. Today, I'm delighted to introduce Dr. Sarah Sperry. Dr. Sperry is an assistant professor of psychiatry and adjunct assistant professor of psychology at the University of Michigan, where she directs the Emotion and Temporal Dynamics, otherwise known as the EME lab. She was a 2022 Young Investigator. Our webinar will begin with Dr. Sperry's presentation, which will then be followed by Q&A. To submit your questions, please use the Questions tab on the control panel on your screen. Please feel free to submit your questions at any time. Following the presentation, I'll ask as many as possible in the time allotted. And now, I'm pleased to introduce Dr. Sperry. Sarah, the floor is yours.
Thank you so much. Hi, everyone. Thank you for coming, attending in person or watching virtually later. I'm excited to be here today to tell you about my program of research that's focused on the assessment, classification, and treatment of bipolar disorders. Today, I'm going to share with you hot off the press findings from my Brain and Behavior Research Foundation Young Investigator Award that will hopefully challenge the way you think about bipolar disorder. If you're living with bipolar disorder or who have a loved one with bipolar disorder, this presentation will hopefully highlight the importance of engaging in ongoing mood monitoring. If you're a provider, this presentation will hopefully highlight the importance of prescribing mood monitoring to your clients and the value that it might bring. If you're a scientist, this presentation will hopefully highlight the importance of thinking about what our predictors and outcome measures are when doing research with individuals with bipolar disorder. I have no conflicts of interest to report today, but do want to highlight the sources of funding that make this research possible. Today, findings that I'll present will primarily come from my BBRF Young Investigator Award, and I'll also touch on some research from a small grant from the American Psychological Foundation and a collaborative grant funded by the Bazooki Brain Research Fund. For those who don't know, bipolar disorder is one of the top 10 leading causes of disability worldwide. Despite this, progress in terms of diagnosis and treatment remains fairly stagnant. Today, I'm going to share with you my ideas about why this might be, what we might be missing, and how we might be able to move forward to catalyze change in the field. Recognizing that people on this webinar come from all different walks of life, I'm going to briefly review our current diagnostic criteria for bipolar disorder so that we're all on the same page moving forward. Bipolar disorder is comprised of mood episodes either manic, hypomanic, depressive, or mixed episodes. I'll briefly review what each is. First, individuals with bipolar disorder may experience manic episodes. These involve feelings of elation, euphoria, and/or agitation and irritability, increased energy and a reduced need for sleep, feeling grandiose or invincible or superior, talking more and faster than normal, having racing thoughts, being hyper-focused on an activity or goal, pacing or feeling really restless and fidgety, being impulsive or reckless, and for some, experiencing delusions and hallucinations. Now, for something to be categorized as a manic episode, these symptoms have to last at least 1 week or shorter if they require hospitalization. And critically, they cause significant impairment in one's social life, health, home, or occupational places of work. Hypomanic episodes are similar to manic episodes, but differ in duration and intensity. So this is the same set of symptoms you just saw, but here the symptoms only have to last 4 days. And different than mania, they tend not to cause clinically significant impairment, but they must involve a recognizable and observable change in somebody's affect and behavior. So often it's visible by family and friends. It is an unequivocal change. Individuals with bipolar disorder may also experience depressive episodes that can include prolonged sad and low mood, loss of energy, loss of interest in pleasurable activities, feelings of worthlessness or guilt, withdrawal from social activities and family, appetite and weight changes, difficulty concentrating and making decisions, sleep changes such as insomnia or hypersomnia, and thoughts of death or suicide. And these symptoms must be present for at least 2 weeks and cause clinically significant impairment. Last, individuals with bipolar disorder sometimes experience mixed episodes, where they have symptoms of mania or hypomania and depression at the same time. Now, the type of episode one experiences determines which bipolar diagnosis they receive. We have 4 primary possible diagnoses in our current diagnostic system, the DSM-5. That is bipolar 1 disorder, bipolar 2 disorder, other or unspecified bipolar disorder, previously known as bipolar NOS, not otherwise specified, and cyclothymic disorder. Let's take a look at each of these diagnoses visually so that everybody understands how they are similar and different. Individuals with bipolar 1 disorder must have a history of manic episodes. It's not required that they have experienced depressive episodes. However, the majority with this diagnosis do experience depression in addition to mania. Let's break down this figure. Here we have 56 weeks along the x-axis, representing just over a year. The dashed orange line here represents the cutoff for clinically significant depressive symptoms. And the dashed black line represents the cutoff for clinically significant manic symptoms. The solid orange line represents the hypothetical individual's depressive symptoms, and the solid black line represents their manic symptoms. So what you can see here is that over the past roughly year, this individual has 1 pronounced depressive episode, 1 pronounced manic episode, and 1 mixed episode where they're experiencing symptoms of both mania and depression. Now, what you'll notice is that between episodes, the individual has no mood disturbances, so their scores are down at 0. This is important because extant research and clinical theorizing often emphasize that the difference between bipolar disorder and those with things like primary psychotic disorders or schizophrenia or borderline personality disorder was that there was a return to normal, or what we call euthymia, in between episodes. Here's a hypothetical individual with bipolar II disorder. Individuals with bipolar II disorder, by definition, have to have at least one hypomanic episode and experience depressive episodes. This figure is oriented the same as the last, but the black dashed line is lower, representing the lower intensity of hypomania compared to mania. What we see here is that this individual has 3 prominent depressive episodes with 3 hypomanic episodes, one of which overlaps in some time with the depressive episode. But again, here you see that outside of these discrete episodes, the individual is euthymic, and I'm using air quotes if you could see me, or without mood. This is a hypothetical individual with cyclothymic disorder. Cyclothymia is when an individual has symptoms of both hypomania and depression that do not meet full criteria, either in duration or intensity. And these symptoms must be present for a significant amount of time. So you'll see here a lot of variability, a lot of vacillation between symptoms, and less time overall spent in euthymia without mood disturbances. Now, these figures are beautiful and they map onto our diagnostic criteria very nicely. However, I'm here to tell you that things do not look this clean in real world data. I'm going to start to show this to you. So first, I'm going to show you some preliminary findings from one of our studies called Priori Ambient here at University of Michigan, in which we had 18 individuals with bipolar I or II disorder complete weekly ratings of depression and mania for 12 months. They did so on an application on their smartphone using a measure called the DigiBP, which was developed by our group here at Michigan. This questionnaire includes 6 items that result in a depression score, or D score, and mania score, or M score. Now, these scores have clinical cutoffs based on prediction from our gold standard clinical interviews, the Young Mania Rating Scale and the Hamilton Depression Rating Scale. I'm going to show you what it looks like for a participant to complete this short mood assessment once per week and how easy it is. And we're done. Nice and quick. So here, I'm going to plot the real world data for one of our participants who completed the full 12-month study and a little extra. This is oriented the same as the initial figures you saw, with the dashed lines representing clinical cutoffs, the solid orange line representing depressive symptoms, and the solid black line representing mania symptoms. Now, what you can see from this one participant is that there are very rarely periods of time when they are actually at 0 or without mood symptoms. Rather, they vacillate between symptoms much more like the theoretical cyclothymic individual seen earlier. But they do have times where they have spikes that represent discrete clinically significant episodes. You'll also note that they often have some level of depressive and manic symptoms at the same time. There's not this clear-cut differentiation between depression and mania. Here's 4 other participants. I selected these simply because there are 4 of our other participants who have completed the full 12-month protocol. And what you'll see here and notice is some individual differences in these patterns. For example, the individuals on the bottom spend more time at 0 in terms of manic symptoms and look a bit closer to our theoretical examples of bipolar I and II disorder seen earlier. But they have a lot more variability in depressive symptoms. You'll note that the individual on the top left experiences frequent but small shifts in manic symptoms, whereas their depression is consistently high and variable. Now I'm going to go to some different data to further show you some time series. We're going to go back in time to graduate school when I had individuals at risk for bipolar disorder rate their negative emotions several times per day for 14 days, so a much shorter period of time. What you see here is a random sample of individuals from this study and their negative emotions plotted over 14 days. You can visually see again that there are significant individual differences in what these time series and patterns look like. My dissertation study found that individuals with a higher level of variability and instability in these time series were more likely to score high on a measure of risk for bipolar disorder. In fact, in one study, we followed people up 3 years later and found that instability in these time series predicted the development of bipolar disorder 3 years later, but not unipolar major depressive disorder. So this instability seemed unique to predicting risk for bipolar disorder. So my first 8 years in my program of research and some of those studies really emphasized to me that individuals differ significantly in their presentation and course, and that this heterogeneity is complex and a challenge for research and treatment. Furthermore, I emphasize that affective instability, or the variability in those time series, is present throughout much of the course, even outside the context of discrete mood episodes. So this conceptual theory of euthymia, when people are completely back to normal, no mood symptoms, doesn't seem to be that characteristic of people with bipolar disorder. The question I started to ask myself was, can we stratify individuals based on these patterns of affective instability rather than the type of episode that they experience or the diagnosis they come with? So in other words, if I took those 5 time series from the priori study I showed you, I could use models to say, how do these individuals differ from each other in their actual dynamics of their depression and mania? And thankfully, the Brain and Behavior Research Foundation liked this idea and question. So I want to say thank you especially to Thomas and Nancy Coles, who sponsored my Young Investigator Award, for my project to look at modeling and predicting mood dynamics, a precision health approach to bipolar disorder. In this project, which started mid last year, I proposed to look at a unique longitudinal cohort of individuals with bipolar disorder, the Proctor Longitudinal Study at the University of Michigan. This unique cohort includes about 1,400 individuals who have been followed from anywhere from 0 to 16 years. It's an ongoing study. We're still enrolling people, so that's why we have 0. Now, of the 1,400, about 70% have a bipolar spectrum disorder. About 20% have no psychiatric diagnosis and are considered healthy comparison subjects. And about 13% are considered psychiatric comparisons. These are folks with non-affective diagnoses, major depressive disorder, non-bipolar diagnoses. For my project, I proposed to take those individuals with a bipolar 1, 2, or NOS diagnosis who had at least 5 years of data to model over time. This allowed me to have a sample size of 731 individuals. About 70% have bipolar 1, about 20% have bipolar 2, and just shy of 10% have a bipolar NOS diagnosis. Now, what do people do in this longitudinal study? When they enroll, they go through a baseline assessment that includes an extensive diagnostic interview. They give biological samples, and they fill out many questionnaires and do interviews about trauma history, personality, temperament, family history, and neurocognitive functioning. After baseline, every 2 months, they complete self-report measures of mood and functioning. Every 6 months, they complete self-report measures on substance use and sleep quality. Each year, they undergo a clinical assessment where we rate their manic and depressive symptoms using the gold standard YMARS and HAM-D, and also complete some additional measures on family dynamics, chronotype, and do a med update. At year 2, or every 2 years, they undergo a comprehensive interview that updates their medical, diagnostic, and treatment history, and also any interval suicide history. And every 5 years, they undergo a reassessment of their neurocognitive functioning and personality. What's even more exciting is that for many of these individuals, we are able to integrate this data with their electronic health record data, allowing us to really garner a lot of deep phenotyping information about folks to try to predict treatment response, trajectories of change, and so on. The data that I'm presenting today is going to focus on primarily 2 measures that are given every 2 months. So these are our self-report measures of depression, which is the PHQ-9, and mania, the Altman self-rating mania scale. And many of you who have been in therapy or gone to appointments at medical systems have likely filled out these questionnaires as a part of your routine care. Later, I'll talk about another measure that is administered at this point in time, what's called the SF-12, which measures mental and physical health functioning. What's really unique about this cohort is that because I have 731 individuals with bipolar disorder and up to 16 years of data, this results in 22,792 depression measures and 23,106 mania measures that I'm able to model over time. For somebody like me, this is very exciting. So here is 6 individuals that have been in the study for over 10 years. These figures are the same as before. So our dashed lines represent the clinical cutoffs. The solid black line represents mania, solid orange line represents depression. What you'll see is that, again, we have a lot of variability, but we also have a lot of individual differences. So the individual down on the bottom left clearly spends most of their time over 10 years in depression, but they have episodes of maybe hypomania or mania dispersed throughout. Other individuals have really vacillating, variable cycles where they're experiencing both depression and manic-like symptoms over time. So again, we have individual differences. Let's narrow in on one of them. So this is one of what I'll call the time series from one of our participants. About 10 years of data. How can I take this data and start to create ways of seeing how people are similar and different? I could just look at these all day and try to group people, but that's not very scientifically sound. So what I do is I use a method called dynamic structural equation modeling. I'm not going to get into the specifics of that, but that allows me to take these time series and extract values from it that represent what the time series looks like. So I'm going to go through 6 of these. I'm not going to go into the math, but I am going to conceptually describe what each of them represents. First, we can get somebody's mean over time of their depression and mania. So the thick, solid orange line represents this individual's depression mean, and the black line represents their mania mean. Conceptually, we think about these means as the average level of depression or mania that somebody experiences. And if we're thinking about a system, we could think about this as somebody's home base. It's the place that their body inherently goes back to most of the time. Next, we can look at what's called variability. This is how much conceptually a person deviates away from their home base. So how intense or less intense are these symptoms compared to what they look like on average? And mathematically, this is just kind of the amplitude of the time series. So we can assess that separately for mania and depression. Lastly, we have the autocorrelation. Statistically, this is just how much mood at one point in time predicts mood at the next point in time, and so on and so forth. Conceptually, we think about this as a representation of how long it takes an individual to return to baseline when they do react, or it can just represent how much mood is consistent over time. So if you look at this black bar here, where mania is at 0 for many, many months, there would be a high autocorrelation there because mood is the same. So if I try to predict the next one, I'm going to predict it with pretty good accuracy because it's been the same for a while. Versus our depressive symptoms, it's going to be a much lower autocorrelation because we have so much more variability. So for each of my 731 individuals with bipolar disorder, I can put their time series of depression and mania data through this model and extract these 6 variables. Again, depression and mania, mean, variability, and autocorrelation. Then what I can do is ask, of my 731 people, how do people differ and look the same across these 6 factors? So can I group people or stratify people based on the temporal dynamics of their mood? We do this through a method called latent profile analysis. I won't get into the nitty-gritty of that, but essentially what it does is it tries to identify the ideal number of groups that best matches people and accounts for the most variability between people using these 6 variables. So a latent profile analysis might tell us, oh, we can break these folks up into 4 groups or 3 groups or 2 groups. And it gives us ways to analyze the groups to pick the best fitting solution. For our data on our 731 individuals with bipolar disorder, we found 2 meaningful groups. I'm just going to call them group 1 and group 2 for simplicity's sake. 253 of our individuals fell into group 1, and 478 of our individuals fell into group 2. Now, for the scientists on the call, we have some class probabilities here, but for our non-scientist, what this essentially represents is the chance that if somebody's in a certain group, that they'll end up in that group. So you want to see high probabilities for group 1 and group 1, which we see is about 90%. What that means is that if you truly belong in group 1, 90% of the time, this model is going to assign you to group 1. If you're truly in group 2, 97% of the time, this model is going to put you in group 2. So these are the types of numbers you want to see. This means that there's really good discrimination between these groups and that they truly are separate. Now, what made these groups come out? How are they different? Back to my plots. This time I took everybody's data and I found the average level of depression and mania for that group at each point in time. So this solid black line represents depression for everybody in the group 2 over time. The black dashed line represents group 2's mania over time. The solid orange represents group 1's depression, and the dashed line represents group 1's mania. So what we can see visually right off the bat is that group 2 tends to have higher mean levels of depression and mania. I also see visually that it looks like group 2 might have more variability in their scores. Now it's important to note, because I'm averaging over, close to 500 people in group 2, that the variability is going to be reduced. And so it likely looks bigger than this if you were to plot every single person. Nonetheless, I want to be able to say scientifically and test it statistically, do these groups differ on these two factors that I'm observing? The first way we can look at that is to plot those 6 variables we use to create our classes on the x-axis. So here we have depression, mean variability and autocorrelation, mania, mean variability and autocorrelation. Each of these dots represents one of the 731 individuals. Dots are in orange are people who got assigned to group 1. Dots in gray are people who got assigned to group 2. Again, looking at this visually, for both mean and variability, we can see that people who got assigned to group 2 have higher mean scores and more variable mean scores in both depression and mania. When we look at autocorrelation, the picture is a bit more mixed. It looks like group 1 and 2 aren't differentiating much on the autocorrelation. Now let's test this statistically. These are what are called violin plots. Let me take you through what they mean. I'm going to orient you to this upper left-hand corner where we have depression mean. The funny looking figure in orange represents those in group 1 and gray in group 2. The width of the violin plot represents how many people are falling into that level. So we see the widest part of this violin plot at around 5, which reflects that group's mean. For group 2, we see the widest part around 10, which represents that group's mean. And what we can see via these solid black lines in the box plot is that group 2 has a much higher mean than group 1. And I'm not showing you the numbers here, but this is statistically significant. The same is true for variability. This higher level of variability, about a 5 compared to about a 3, is statistically different. So group 2 has higher variability in terms of depression. We see virtually no difference in the autocorrelation. And the same exact pattern emerges for mania. Higher mean mania, higher mean mania variability, and no difference in autocorrelation. So what we can conclude is that group 2 are individuals with bipolar disorder whose course is characterized by high intensity of symptoms, but more importantly to my talk, high variability in these symptoms. And I'll remind you that all of these individuals have bipolar disorder. The next question I wanted to ask is, are there predictors that help us know who likely gets classified into group 1 or group 2? For today's presentation, because the grant isn't done, I'm going to focus on our diagnostic and demographic variables that might help us understand some differences about these two groups. So using a logistic regression model, which tells us how do these predictors predict the odds of ending up in group 1 or group 2, we tested the relationship between age of onset of manic, hypomanic, and depressive episodes, number of episodes of mania, hypomania, and depression, sex at birth, race, and diagnosis. What we found is that these 4 variables predicted group membership, such that those with a younger age of onset of mania or hypomania, older age of onset of depression, and a greater number of episodes of mania were more likely to get classified as group 2. We also found that people of color tended to be classified into group 2. Most importantly, I think, to my message, though, is that we saw that diagnostic status did not predict group membership. And if you remember, our diagnostic criteria are supposed to tell us something about the course and episodic nature of the illness. But here, diagnosis doesn't differentiate somebody's level of affective instability. We don't have an overrepresentation of something like bipolar 1 in group 2. My next question was, does group membership predict outcomes? we looked at whether being assigned into group 1 or group 2 predicted mental and physical health functioning. And if you remember, this is an instrument that was administered every 2 months for the duration of the study. So we're able to look at how this group membership predicts mental and physical health functioning over time or longitudinally. What we found is that group 2, individuals in group 2, have lower mental and physical health functioning over the course of their illness by an average of about half a standard deviation, which in terms of our research is a significant effect. That's very notable. So what we've learned so far is that, one, individuals with bipolar disorder do seem to experience inner episodic affective instability. It doesn't seem to, the most common pattern doesn't seem to be euthymia with no mood symptoms to a discrete episode and back. 2, we found that individuals with bipolar disorder can be stratified into a group with higher instability and a group with lower instability. We found that demographics and age of onset differentially predict group membership. And we found that group membership predicts functioning. Now, you might be asking yourself, what about all those other measures you get in that longitudinal study? Thanks for asking. Here are the next steps for this grant, which has another year left. We're a little over a year left. Going back to the protocol, we aim to look at everything that we're able to collect on these folks and how that might be able to predict group membership and how group membership might predict outcomes that we measure within the study. And key to this is that, again, we can integrate the study that we collect in our protocol and electronic health record data. So this was the figure I had in my grant, which showed that the aim 1 was to first model these mood dynamics and try to identify classes based on them. Check, we've done that. Now aim 2 is to fully invest and see whether biopsychosocial predictors predict group membership and whether group membership predicts outcomes. So what are the things I'm focusing on specifically? First, I'm going to be looking at whether sleep and circadian rhythms, trauma history, personality and temperament, family history, and health comorbidities predict group membership. So this would help us know if somebody came into a clinic or a research study and they had a certain set of factors about their history, we might have a sense that they're more likely to have a course that's similar to group 2 than group 1. I also care about whether group membership predicts outcomes. So I'm going to be looking at things like ER visits and hospitalizations, substance use, neurocognitive functioning, suicide risk, quality of life, and medication and therapy response. So how can this type of project or this type of finding impact who gets what treatment? After all, my talk is a precision health approach to bipolar disorder. In our current system, both in research and in clinical practice, you might come into the office and get what we call a traditional diagnostic interview. This might be hours of questions about your history and your symptoms and their patterns. We might do some review of your medical chart or talk to caregivers. And from this diagnostic interview, we assign you a diagnosis, maybe bipolar 1, 2, NOS, or cyclothymia. From there, we tend to pick our treatments. We have guidelines that say what is the best treatment for bipolar 1 disorder, what is the best treatment for bipolar 2 disorder, and then we don't have really strong guidelines for bipolar NOS or cyclothymia, so I put question marks there. But in general, we choose our treatments based on the diagnosis itself. And if treatment doesn't work, we reevaluate, we try something else, we have second-line treatments, third-line treatments, and go from there. What I'm proposing that could be helpful to our field is that when somebody comes in for a diagnostic interview, a part of that is that you do some mood monitoring. You all saw how quick it was to fill out the DigiBP. That took us about 30 seconds to watch. What if our patients and our research participants were sent out into their environment and filled out this questionnaire once a day for 14 days? That would give us a time series for them in terms of their depression and mania, and we might be able to classify them based on that time series as to whether they're more like individuals who have low variability and kind of a more episodic course versus those in group 2 who have more variability, and that variability itself is chronic. And what I propose is that I think we need to start developing treatments and thinking about treatments for the constructive affective instability rather than the diagnosis of bipolar 1 or 2 separately. Now, this is my opinion based on my program of research, and I know that it's probably contentious, but the data shows me that classifying people by affective instability is potentially more meaningful in some models than diagnosis alone. So what if we had treatments that mapped onto whether people, the actual presentation of their symptoms versus a diagnosis? So that's my pipe dream. Now, you may be asking yourself, not everybody is in this nice longitudinal research cohort like we have here at University of Michigan. We're lucky. How can we measure and classify people in real-world clinical settings? How can this be more generalizable? Well, most medical systems now implement what's called measurement-based care. Measurement-based care is where when you sign in for an appointment, either in person or virtually, you often get a set of questionnaires you're asked when you're checking in for your visit. Here at University of Michigan, when I sign into my U of M Health, no matter what kind of appointment I go to, whether it's primary care, if it's a specialist, everybody gets asked the PHQ-9 measure of depression and the G87 measure of anxiety. That's standard practice now for our health system. So people who aren't even engaged in research studies or engaged in a department of psychiatry may have data that allows us to model what their mood dynamics look like. So how would we use that data? Well, my collaborator, Dr. Anastasia Yoakum, and I went back to the full cohort of roughly 1,400 and said, can we think about what the shortest amount of time or the fewest measures would allow us to meaningfully separate people based on their means and variability? So if we take the full, 10 years of the study, our question is can we separate people based on variability of measures over 6 months, over 12 months, over 24 months, and so on? To measure variability itself, you have to have at least more than 2 points in time. Otherwise, you're just going to get a slope. So what we decided on for this study was 12 months. For most people, this gave us 3 to 4 measurements of the PHQ-9. And most patients are involved in care for at least a year. So with that, we calculated the variability of their PHQ-9 over those 12 months. And we plotted it here for people with bipolar spectrum disorders, for healthy comparison subjects, and those psychiatric comparisons. We also took everybody's data and we tried to parse them into groups based on average, moderate, and high levels of variability. So what you see here again is each dot represents a person. We have a bipolar on the left, other psychiatric diagnoses on the right, and healthy controls in the middle. The solid red line represents those who fall above in the moderate category. They're over the 60th percentile. And those above the dashed line fall into the high instability or variability category, over the 95th percentile. Now, we did a statistical test that tested whether more people with bipolar disorder are in the moderate and high instability category, accounting for the fact that there's different numbers of people in these categories. And the visuals tell the story that the statistics told. Individuals with bipolar disorders were much more likely to be classified in the moderate and high variability groups. And this is again just based on a few measures over 12 months. So we concluded that you can stratify people based on variability with measures taken just over 12 months. Now, I wanted to mirror my earlier analysis of the data over 10 years and see, well, can this 12-month measure also predict functioning? So here, I looked at whether those in the average, moderate, and high instability groups predicted mental and physical health functioning. And what we found is that if you're in the moderate variability or high variability groups compared to the average group, your functioning level is between 1/4 to 1/2 of a standard deviation below those in average variability. And if you remember, when we looked at this with the longitudinal data, we saw almost the same exact number. So those in group 2 had a functioning level about 1/2 a standard deviation below. So this simpler, easy model that could be implemented clinically finds the same thing, that variability and instability itself predicts functioning. So individuals can be stratified into groups based on affective instability, even with just a few measures. And this can be done with traditional patient-reported outcome measures or PROMs, like the PHQ-9, that are often delivered now in the context of routine physical and mental health care. So my takeaway from this is that affective instability is something we must pay more attention to. Now, how can we implement this in therapy and clinical trials? If you're a patient, if you're a provider, if you're a researcher, all of this applies to you. Let's say this hypothetical individual comes in and decides to elect into therapy. They have bipolar disorder, and they complete 18 sessions with a therapist. And the therapist decides to give a PHQ-9 at each appointment. We can plot that over time. So the orange line here is their PHQ-9 scores. In traditional measurement-based care, we think about a pre-post. We plot a line from the first measurement to the last. And if that line has a significant slope, then we say treatment worked. If the difference between pre and post treatment is a certain number that's clinically significant, we're good to go. This slope looks pretty big, but it might actually not be statistically significant, and we might conclude they haven't made as much progress as we would hope. But if we take my perspective about variability, we might look at this data differently. We might look at the amplitude of their depression or variability of their depression over their course of therapy. In other words, we might do this. We might look at the amplitude of their depression in the first half of treatment and the amplitude of depression in the second half of treatment. What I think is pretty obvious here is that even though the slope from pre to post wasn't necessarily dramatic, the amplitude of variability of their depression is about half post-treatment. Does this mean that treatment worked? I'm not sure, because people think, don't look at this yet, but I'm proposing they do. But I would hypothesize that reducing the reactivity and variability of mood should be a key outcome of treatment. We can also do this with our clinical trials. When you go into a clinical trial, most people will get a measure at pre-treatment, before you start, mid-treatment, post-treatment, and follow-up. And in these large, well-funded clinical trials, we often think about success as a significant slope decrease from pre-treatment to post-treatment. And we're averaging that over hundreds of individuals. So in this treatment trial, we see that on average, people's depression reduces from a 12 to an 8 post-treatment. That's not going to be clinically significant or meaningful in a statistical analysis. And so we might conclude that the treatment doesn't work and stop exploring it. What if we gave everybody a PHQ-9 each week, or the Digi-BP on their smartphone each week, and we plotted that? Here's the full treatment trial. we've got our same slope line from before that wasn't significant, that led us to conclude that depression didn't significantly reduce. Well, what if we looked at the amplitude? First half of treatment, amplitude is really large. Later, it reduces in size by over 50%. So we might have concluded that this treatment didn't work in reducing depressive symptoms, when we might have just been hiding the fact that it worked on reducing variability in depression, which could be an important indicator of functioning in bipolar disorder. So with that, I would argue that you can measure and use affective instability as a treatment outcome measure and as a way to classify individuals, and is an important part of bipolar disorder that the field largely has not been paying attention to. So with that, I'd like to thank many people. We have the Emote Lab in the upper left, my BBRF mentor, Dr. Ivy Cho, and the entire Heinz C. Prechter Bipolar Research Program, for whom this longitudinal study would not be possible. I'd like to thank all the participants who are in the longitudinal study, for whom this research would not be possible. And I'd also like to thank the Prechter family and Dr. Melvin McGinnis and others. Without your support and vision, the PLS-BD would not exist, nor would my research. And lastly, I want to say a special thank you to Dr. Anastasia Yoakum, circled here in orange, who was very helpful in the latter half of this presentation when thinking about what is the optimal amount of time that we measure this variability. And with that, I'll leave you with our websites for both the Emote Lab and the Prechter program, and open it up for a couple of minutes of questions.
Well, Sarah, thank you for an excellent presentation. Really, you were able to present it in a way that I think is understandable to a lay audience. And you made your point that really is extremely interesting. I want to pick up a little bit in terms of this affective instability and variability that you're speaking of, and measuring that. In addition to the PHQ and some of the other measurements, are there other measurements that one might use, such as one of the smart watches or smartphones, etc., that can monitor people's activities, their sleep, etc., that might be useful as well?
That's a fantastic question. And if I had more time, I would show you my other research studies that are asking that exact question. So yes, we're exploring several what we call passive methods, or passive digital phenotyping methods, of trying to pick up on this variability and reductions in this variability. The primary things that we're focusing on as a program and as a research lab are speech. So this is in collaboration with Dr. Emily Maurer Provost here at the University of Michigan, who's developed algorithms that take speech and give us emotion ratings from those speech. So we're looking at the variability of that, and whether variability in emotion derived from speech without people having to, answer questionnaires allows us to predict the same things. And we're also doing the same with Fitbits, looking at sleep and circadian rhythms. I have a study that shows that variability in sleep, again, not sleeping less, not sleeping more, but the chaos of having your bed and wake times change from night to night, that variability is actually a really robust predictor of mood instability. So variability, across not just mood seems to be really important in bipolar disorder. And we're definitely hoping to develop, more passive systems that don't require as much burden on individuals to, engage in self-awareness and fill out a questionnaire and remember to do
that. I think that's great. We often think of, as you said, this point and that point. When the person comes to an appointment with their doctor, how are you today compared to a couple of weeks ago? But the reality is there's all this time in between, and being able to monitor that can make a big difference in understanding how the person is doing. So I think this approach has tremendous potential. I want to ask you about one of the challenges is making that initial diagnosis. And I'm curious about making use of this data to sort of help with that early diagnosis so there could be an early intervention for bipolar.
Yeah, that's a great question. And that was a big part of why I ran one of those studies in graduate school, where I was looking at whether the variability of the time series significantly differentiated who went on to develop a bipolar disorder, who didn't, or who went on to develop a unipolar diagnosis. And what you'll remember is that the more variable both positive and negative mood were for those folks over just 14 days, that predicted the development of a bipolar disorder 3 years later, but not unipolar. So I think there is potential of this method if, especially in our teenagers, if they're coming into the office and we have, both unipolar and bipolar depression on the table. We're notoriously bad at figuring out who's going to go on to stay MDD and who's going to go on to develop bipolar disorder. And I think one of the things that we could do, and the future that I see, is that, yeah, maybe they get it outfitted with a Fitbit, maybe they have a speech analyzer, or maybe they're filling out these questionnaires for a month and their provider looks at it, and maybe that variability itself is a signal that might indicate they're more likely to develop a bipolar disorder than unipolar. And that has implications for what treatment regimen we might choose first, right? We might not put them right on an SSRI out of fear of inducing mania if we think that there's that risk of bipolar disorder. So I would argue that it also has tremendous potential in the diagnostics. Yeah. Good.
One last question. You spoke a little bit about the ongoing work that you're doing. Where do you see this down the road in let's say 5 or 10 years from now? What would be your dream about how this research moves forward and then how it's able to help people?
Yeah. I think the most profound impact it can have is helping us choose treatments that work on outcomes that are most impairing to the individual. As a clinical psychologist, so often I see that the primary goal of therapy is reducing depression or reducing manic symptoms or reducing anxiety symptoms. And I feel like sometimes that does our patients a disservice because we're not considering what is actually necessarily getting in the way of their day-to-day functioning impairment. And we now have many studies, not just from my lab, but other labs, that shows that this variability and instability in between episodes is one of the strongest predictors of functioning. So if 5 to 10 years from now, we have therapies that are focused on reducing the affective instability versus just psychoeducation about episodes and relapse prevention, I would feel like that's a huge win. Now, we can pull therapies from other disorders like borderline that focus on affective instability and start to build this into programs for bipolar disorder, but we're not quite there yet. And I think we need research like this to convince everybody that we should be looking at the instability itself as an outcome of our treatments.
Well, Sarah, I just want to say thank you so much for taking the time to do this presentation for us, but more importantly, the ongoing work that you've done and will continue to do. Your passion for this comes across so clearly, and I appreciate your doing this. I also want to thank everybody who joined us today, and would ask people to please consider making a donation to BBRF today. 100% of every dollar donated for research is invested in our research grants. We're able to do this because our operating expenses are covered by separate foundation grants. That means that when you donate $1 for research, that dollar goes directly to the scientist. To make a gift, please visit our website, BBRFoundation.org, or call us at 1-800-829-8289. This webinar has been recorded. If you've missed any portion of the presentation or would like to share it, please visit the events and webinars page on our website. And I'd like to invite people to please join us again on October 10th at 2 p.m. Eastern Time, when Dr. Mindy Westlund Scherner, an assistant professor at the University of Utah, will present self-injurious thoughts and behaviors in youth. Thank you, and remember, together we can dramatically improve the lives of those living with mental illness and enable more people to live full, happy, and productive lives. Thank you.